All right, hello everyone. Thank you so much for joining us today. My name is Emma Sears. I'm the programs coordinator at the Parkinson Association of the Rockies. And I would like to introduce our webinar today, generally sponsored by Abbott. Before we begin, I just have a few reminders. We will have questions at the end, and there's two ways that you can ask a question, either by typing it into the question bar and submitting it, and then I can read them out at the end, or pressing the little hand that will notify me that you have a question, and then I can unmute you and you can ask the question yourself at the end. There will be an after webinar survey, which I would appreciate if all of you filled that out. And then this webinar will be recorded. And with that, I will turn it over to Cindy from Abbott.
Hello, welcome everyone. Thanks for joining the program tonight. First, I'd like to thank Emma as well and the Parkinson Association for allowing Abbott to sponsor tonight's event. And with that, again, my name is Cindy Kirkendall. I support all of the hospitals and the providers in Colorado and Wyoming that offer Abbott DBS. And as many of you know, DBS has really become kind of a standard of care for treatment for patients with Parkinson's disease with motor fluctuations or symptoms that are not any longer responding to medications. We also are FDA approved for the treatment of essential tremor. And now probably more than ever, it's important as you're researching DBS as a treatment option to really do your research because there's many options both from a implant perspective as well as surgical workflow and surgical technology that's available to have the leads put in. So that's really what we'll be discussing tonight. Dr. David Van Sickle is our guest speaker. He is a neurosurgeon. He practices at Littleton Adventist Hospital and is the co-founder of the Denver DBS Center. Dr. Van Sickle has really dedicated a large portion of his career to improving the procedure and really bringing innovation to DBS. He was one of the first in the world to perform a sleep robotic DBS surgery, and since that time has trained physicians from all over the world implementing these new techniques. So he will be talking a lot about what's new with DBS tonight, what's new with the technology, and important considerations as you consider DBS as a treatment option. So with that, I will turn it over to Dr. Van Sickle.
Thanks, Cindy. Thank you, everybody, for joining. I've been in neurosurgeon and been in practice now for about 16 years. I did the first DBS case in the second year in practice, and then have continued to do DBS for about 15 years in practice now. As Cindy said, I've devoted a good chunk of my practice to doing deep brain stimulation, though I do many other things as well. Hopefully the talk tonight can serve as an introduction to deep brain stimulation if you're considering it, or if you have a loved one who's considering it, but also can show some of the advancements that have been made in the last 5 to 7 years, which really have changed the surgery from something that was maybe considered a bit experimental to something now that would be considered completely standard of care and should be considered early in the disease process. So hopefully everybody can see what I'm looking at. It says deep brain stimulation. It's the webinar. And I'm going to run through a series of slides. And at the end, I'm going to show some videos as well. And I think those are probably, if you see anything, you should probably see the videos. The rest of it you could forget. The videos of some patients will really show you what's going on and what can be achieved. So what is DBS? So the history of it, the first DBS operation was done by a gentleman named Dr. Alim Louis Benabid. It was done in France. It was in a ski area of France, Grenoble, France, in 1987. So it's not a new surgery. It's been around for a long time. The surgery has bounced back and forth across the Atlantic multiple times. The first surgeries before this were lesion surgeries. So you would put a probe down in the brain and kill off an area of brain that was overacting and thereby treat the disease process. And those go back actually to the 1960s. They obviously had a lot of problems associated with them. Dr. Benabid's team was trying to improve those surgeries by experimenting with finding the right area by stimulating, and then ultimately said, well, why don't we just not kill anything? Why don't we just keep stimulating? And hence DBS was born. Deep brain stimulation has the advantage over lesioning surgery of being able to be modulated. It can be turned up, can be turned down, can be turned off, can be removed. and is generally speaking non-destructive. So what is it? It looks like a pacemaker for the brain, is probably the simplest way to put it. And so you have, hopefully you can see my arrow here, you have these generators which contain a battery as well as some electronics which creates pulses which travel up the wires and then travel to these electrodes which go deep in the brain, and hence the name. And then there's, generally speaking, we do one for each side of the brain. So the right side of this gentleman's brain treats the left side of his body, and the left side of the brain treats the right side of the body. And generally speaking, if you have Parkinson's disease, you want to treat both. There are several devices now on the market. This is a picture of one with the various different components to it. The Infinity 5 generator is what I primarily use. That's this smaller one here. Let me move my thing there. This little cap here is what holds it on the surface of the skull and holds it in place when I place it. The electrode here is what goes in the brain. The iPhone here actually is the software that you would have yourself or your loved one would have to make any small adjustments to their device if necessary, or just to check the battery. And the software now can be loaded on anybody's iPhone, so it can be loaded on your own iPhone and is quite secure. And then this iPad here, which actually is a physical iPad made by Apple, is what's used for your clinician. That is oftentimes your neurologist, in order to make adjustments to the contacts where the stimulation occurs. And so all of these things are necessary in order to make a suite of projects. One new thing that I won't spend too much time on, but I think is actually groundbreaking for our community, given that we have a rural population, is the fact that nowadays your clinician doesn't have to be with you to do the programming. You can actually show video on the iPad of you connected to your phone, and then therefore your clinician can make changes to your device based on the symptoms you display on the video. So you could be, for example, in Lyman, and your clinician could be here in Denver, and you could actually have an entire appointment where adjustments were made to your system to get better symptom control, and you wouldn't have to drive anywhere. So you imagine going to Durango in a winter snowstorm to Denver, or just calling up on the phone for an hour. So that's actually, I think, a really big breakthrough for us here in Colorado. So deep brain stimulation works by putting a stimulator deep into the brain, as we talked about, and there's a couple different targets for Parkinson's. One of them is the GPI, and that's this green area here. It's the inner green area. This outer green area right here is called the GPE. GPI stands for globus pallidus internus. There's no test on this later, but that's where the electrode goes. And that's one of the easier targets for us to hit. One of the more common targets for Parkinson's is the STN, or subthalamic nucleus. And that's one of the smallest targets. And this is a lead actual diameter relative to the STN. And you can see getting that lead in there, there's not much leeway. And one of the themes we'll talk about during the entire presentation is precision. So given how small the STN is, you really have about a 1 millimeter window in any given direction in order to get the lead place where it's going to work well. There's another target that I don't show here called the VIM. The initials for that are actually Latin words, and so it doesn't translate well into English, but it's a portion of the thalamus, which is really up in the area up around here, and that's a great area to put an electrode to control tremor in essential tremor. It can also be used for Parkinson's as well. So how does this work? In all cases, DBS really works by inhibition. And this little cartoon here shows a neuron, and it shows an electrode coming on and zapping this neuron, and that's not really accurate. It's really a capacitive coupling, but it doesn't really matter. But important in this cartoon is this inhibitory afferent. So this is a transmission of an inhibitory neuron going to this neuron, and it's going to slow this neuron down. It's going to inhibit this neuron. Inhibitory neurons are oftentimes dopamine neurons, and dopamine neurons will slow down the action of this target neuron. And as these cells die off, which they do unfortunately in Parkinson's disease, this cell begins to overact. It fires too quickly. And when it fires too quickly, you can get feedback, or which can be physically manifested as tremor. It's a little bit like having not enough dampening, not enough inhibition, dampening like shock absorbers in your car. If the shock absorbers are bad, you can get tremor. If it gets worse, the system starts to lock up entirely and doesn't function. All of the medications for Parkinson's are designed to work either on this inhibitory neuron or on the synapse where it connects to the neuron in question. And if this neuron dies, then the connection also goes away and all the medications cease to function properly. And that's where DBS comes in place. DBS can inhibit this neuron on the outgoing axon without needing this inhibitory neuron to exist. So the dopamine neurons can die off and yet the DBS can still work. Now, if you have essential tremor, you might be thinking, well, how does it work in that case? Well, in that case, it's not a dopamine loss that's the problem. The problem is the genetics. There are neurons that are just genetically overacting, and slowing them down can help rebalance the system. In either case, the firing this electrical signal here at a rate that's really, really quickly, it just tires out this neuron and thereby inhibits it, just like it would have been inhibited naturally. And so we're replacing what nature should be doing. So what does DBS treat? So we'll talk about Parkinson's first. For Parkinson's, DBS treats all of the motor symptoms of Parkinson's. There's motor and non-motor symptoms. Motor symptoms include slowness, which we call bradykinesia, facial expression, rigidity, tremor, freezing, and fine, of course, motor skills. So like doing buttons or trying to get dressed in the morning. Oftentimes people say facial expression is the number one, is not the main reason they did the DBS, but it's their favorite result. So if a husband has DBS, the wife will notice, hey, he expresses his emotions much better. And it's not that the emotions weren't there, it's just that they were difficult to express previously. One thing that's really important to note is that motor symptoms does not include postural instability, which is balance, and does not include dementia. So these are late features in the disease, and we want to treat Parkinson's before these start to occur. It's not necessarily too late if the beginning signs of these occur, but certainly if they become advanced, it can be too late. And that's one of the biggest mistakes that we see in DBS treatment for Parkinson's, is that people wait too long. And we'll talk about that a little bit more. This little cartoon, which you can get right off the internet, is a good cartoon to show all of the motor symptoms of Parkinson's. And we can just go through it: the masked face, the stooped posture, rigid back, forward tilt, reduced arm swings, hand tremor, the flexion, slightly flexed knees, the shuffling, short step gait, and the tremors in the legs. All of these things you see on this cartoon, everything you see here, is treatable by deep brain stimulation. So all these classic manifestations of Parkinson's can be made better with deep brain stimulation. Now for essential tremor is really a one symptom disease. Now there's a couple other minor symptoms that can go with it, but typically is one symptom that's a problem. And it's typified here by this diagram, which shows, you know, before and after, where somebody's trying to draw a spiral and his tremor is quite affecting it. And it can be done quite smoothly after deep brain stimulation, which can treat usually 95% of the tremor that's present. And it's one of those things, and you can answer these questions yourself. If you have difficulty drinking from a cup, if you have to use straws, if you have to use two hands or use a sippy cup, if you have difficulty eating soup or difficulty with utensils or difficulty writing or typing, using a phone, putting on makeup. And probably the number one reason that I see somebody has deep brain stimulation for essential tremor is embarrassment in social situations. That's where the tremor causes other people to look at them in a way that they don't like. And so if those are things that are bothering you, then essential tremor might be treatable by DBS for you. Now, does DBS work? The short answer, I could just simply say, is yes, but I wouldn't expect anybody to just believe and take my word for it. Believe me and take my word for it. In medicine, the way we understand whether something works or doesn't work is by what are called randomized controlled trials. There are classes of evidence in medicine, and the classes of evidence can be rated. So if you take an expert's opinion, so you ask me what my opinion is, that is the worst quality of evidence that we can have. The best quality of evidence we can have is a randomized controlled trial, and specifically a blinded randomized controlled trial. What that means is we have two groups of individuals, one group which did not get the treatment and one group that did get the treatment. And the evaluator, because it's blinded, doesn't know if they got it or didn't get it. And then we see how the groups did relative to each other. For example, with appendicitis, if you have appendicitis and you go and have your appendix out, there is no randomized controlled trial that I know of yet that says you should have your appendix out if you have appendicitis. Now, you probably should if it occurs, because you might die, and we've seen people die if they don't do that. But there is no high quality evidence that says you should take out your appendix if you have appendicitis. But for deep brain stimulation, it's exactly the opposite. We have tremendous high quality evidence. In fact, you can just look at the titles of some of these journals and look at the places where these articles have been published. A randomized trial of deep brain stimulation for Parkinson's disease in the New England Journal of Medicine. Neurostimulation for Parkinson's disease with early motor complications. This is also a randomized controlled trial, also in the New England Journal of Medicine. Journal of the American Medical Association, bilateral deep brain stimulation versus best medical therapy for patients with advanced Parkinson's disease, a randomized controlled trial. Deep brain stimulation in the subthalamic and pars interna of the subthalamic nucleus or the pars interna, so that's the GPI, of the globus pallidus in Parkinson's disease. This is a randomized trial. Another bilateral deep brain stimulation versus best medical therapy of advanced Parkinson's disease, a randomized controlled trial. All of these are randomized controlled trials. This is just some of the early 5 of them. There are many more since then. There's almost nothing else in medicine like this where there's this much evidence that it works. So I think it's been completely put to bed that DBS actually works. Let me show you a few of these, and we can go through just a couple of the early ones that really sort of nailed this down. So this is 6 months after a group of individuals got deep brain stimulation, and a group of individuals didn't get it. They got the best medical therapy that we could come up with. If you look at the dark green bars here, the dark green bars is the improvement in various modalities of a quality of life survey. So the mobility was better, activity of daily living better, emotional well-being is better, stigma, how other people's looked at them was better, bodily discomfort was better. And all of these first ones up until we get to social support are what is called statistically significant, that it is 95% likely that these differences occurred because of the treatment versus because of some random effect. The little gray bars that look like they didn't really improve at all, or in some cases actually got worse, that's the people that didn't get DBS. So really, really powerful evidence that these quality of life indicators were better after deep brain stimulation. The study was repeated later for doing deep brain stimulation later and got exactly the same results, but even better results. So even higher values for the neurostimulation group versus the medical therapy group. The only difference in these patients, they were treated earlier rather than treated later. Another study, the JAMA study, and I just put the conclusion here, said in this randomized controlled trial, deep brain stimulation was more effective than best medical therapy in alleviating disability in patients with moderate to severe Parkinson's disease with no motor complications, or sorry, rather with motor complications responsive to levodopa and no significant cognitive impairment. In other words, they said if you meet the indications, that is you have Parkinson's disease and levodopa is working but not working well enough, and don't have dementia, then DBS is more effective than medical therapy alone. There's one last study that's not a quality of life study that I think is really important. And it's only been done once. It is not a randomized controlled trial, so it's not the highest quality of evidence that we've seen. And ethically, it probably can never be done as a randomized controlled trial when you look at it in detail. This is actually a look back study, or a retrospective study is what we call it. And so you look back over time and you said, okay, some people chose to get the surgery and some people chose not to get the surgery, and what's the difference between them? And what's really interesting, and this was done in England, where the National Health Service has you enrolled in the study whether you like it or not. And so we really got a good chance to see what happened. Now, the study started, I believe, in 2001, it ended in 2011, or started in 2002 and ended in 2012. I can't remember exactly. It was published in 2014. And what's interesting about it is it shows that there's a 40% greater chance of being alive 10 years later if you had DBS than if you didn't have DBS. So that's a 40% greater chance of being alive. And what you're looking at here is called a survival curve, or a Kaplan-Meier curve, a survival curve. Insurance industry uses it. Everybody dies of something at some point. And the blue curve up here is the number of people who are alive that had DBS, and the bottom numbers are by years. And the green curve is the number of people who are alive that didn't have DBS. And you notice the curves separate. I'm going to go back here. Sorry about that. And they actually get about 40% further apart. So why is it that they separate? Why are people living longer and have a greater chance of being alive later if they had deep brain stimulation? Now, again, it's not a randomized controlled trial. It's a look-back trial. But it appears to be that it has to do with the status of the respiratory system. So if your Parkinson's is well treated, of which DBS is a significant part of that good treatment, then you're more active. And if you're more active, your heart and your lungs are better off. And so you're less likely to die of a pulmonary problem. And so you look at the respiratory category, that is much less likely to die in the medical group than in the surgical group. And the same thing was true for the heart disease and the cardiovascular. So there's far fewer deaths in the medical and the surgical group. The surgical, in this case, being red and the medical being blue. So that's kind of switch the colors on us a little bit, make it harder. So it's far more people are dying of respiratory problems or pulmonary problems that didn't have deep brain stimulation, likely because they're not more active. So who is a candidate for DBS? So this is also important. So the FDA recommendations. So the FDA recommendations have changed over the years, and it's been kind of slow to be caught up in the neurology communities. 4 years and 4 months is what you should remember. So 4 years after your first symptom, oftentimes maybe a couple years before you even see a doctor, and about 4 months after the symptoms have not been adequately treated. That means you're having ups and downs with your medication. That's when DBS should be done, in that gap, before balance problems develop and before cognitive problems develop. Oftentimes I hear this misinterpreted where somebody says, oh, I'm in the window, so I'm somewhere between here, so I don't have to get DBS yet because I'm not out of the window. But notice the flaw in that logic. Once you're out of the window, now you can't get DBS, and you've missed all of the practical opportunity to benefit from it. So if you look at the stages of Parkinson's disease, and many people have seen these cartoons before, stage 1, stage 2, stage 3, stage 4, stage 5, when do you do DBS based on that information? Between stage 1 and stage 2. It's actually very early on, or maybe between stage 2 and 3. But you don't wait out here to these later advanced disease states in order to do it. So, and just to drive this point home, is if we look at this Venn diagram here of problems that can occur with Parkinson's disease, this is only some of the problems, but some of the big ones that can cause disability. Early on, tremor can be one of the biggest ones, rigidity and slowness can be one of the biggest ones. And early on, balance problems and cognition problems really aren't important at all, they're small. Late in the disease, the balance problems and cognition problems become the dominant problems that are really affecting an individual. And now the tremor and the slowness and rigidity are still there. In fact, they may be even worse than they were before. But if you do DBS here, you treat the yellow, this light blue, and this lighter red, but these big balance and cognitive problems are still there. And you practically really haven't improved this person's disability. But over here, if you eliminate the tremor, slowness, and rigidity, and you're just left with a little bit of balance problems, a little bit of cognitive problems, almost all the disability is gone. And the person acts as if they don't have Parkinson's anymore, or much less disability state at least. So with essential tremor, who is appropriate for that? It's somebody who has severe disabling essential tremor that's unresponsive to medical therapy. You can do both sides or one side. I didn't mention this with Parkinson's disease, but it's really important with Parkinson's to do both sides. So it makes it very difficult to manage a patient that doesn't have both sides done. And it makes the medications hard to have optimal effect because you end up with one side overtreated, one side undertreated. With essential tremor, it's the opposite. With essential tremor, If you have really bad tremor on one side, but not on the other, there's no reason you can't just do one side. But most people end up doing both. That's common, but most people end up doing both. Notice on this list for essential tremor, there's no mention of dementia or balance issues because it's not generally a part of essential tremor, and therefore is not a limiting factor and doesn't create this sort of window of opportunity. So when you do surgery for essential tremor, is really a big personal choice. It's when you've had enough and it's affecting activities of your daily life sufficiently that you want to intervene. So let's look at the sleep robotic DBS. And as Cindy mentioned, I may have been the first person in the world, and certainly the first person in the Americas, to do a sleep robotic DBS. And we'll look at why it is that we developed this technique and why it's sort of being adopted all across the world now in different ways. So historically, we did all DBS was done awake, and we mostly was done using a frame. And this person's having an essential tremor operation. He looks very happy for being in this operating environment. Generally, people did not look that happy. Keep in mind, I did a sleep DBS, or rather awake DBS for many years before we started doing sleep. And notice he's got these pins on his head and this big arc and ring over his head on the other side of the plastic. It's supposedly, hopefully sterile on the other side, not sterile on this side. And what's happening is this fine wire electrode, the one that's 0.25 millimeters in diameter, is being placed down repeatedly through the brain to try to find just the right area. And then once it's identified, this bigger electrode is placed and left in permanently. That's the one that's 1.27 millimeters in diameter. The way we find the right area is we identify the firing rate of certain cells, and that gives it away. And we can actually hear that on a loudspeaker. You can tell which cells are doing what by the sounds that they make. And it seemed like for many years that this was the best way to do this, because we got confirmation that the electrode was in the right location. And we got to find out what the physiology was of those cells because we could hear the firing rate and see the firing rate, and we could stimulate and actually show that somebody's tremor got better right then and there in the operating room. So you would think that this should be foolproof. And it turns out it really wasn't. And there's a lot of reasons for that. I got a blank slide here, don't know why, but oh, okay, here we go. This is actually just a slide showing multiple different platforms that have been developed over the years. I'll go through this really quickly, and we'll get on to why the older techniques weren't really serving us well. So this is a Lexcel platform. This is the robot we currently use. It's very small. This is a platform that uses an optical device. This is a platform that was made on a 3D printing machine I used to use. This is a platform designed to be used in an MRI. Probably none of these are terribly important for the discussion at hand. So we're going to gloss over that. So here's what was happening. Why that we thought we had a foolproof method, but we invented a better fool. During the operation, we would place these fine wire electrodes down, like I said, and this is actually one of them as shown on a CAT scan that was done live in the operating room. And what they did in this case, instead of putting one electrode in at a time, they put in two. And so you see two electrodes right next to each other. And those electrodes were spaced apart by exactly 2 millimeters. So the tips of those electrodes, as measured by the CAT scan, should be exactly 2 millimeters apart. Except for it turns out they weren't. And they did this a bunch of times in a bunch of patients during surgery. And they measured how far apart these electrodes were rather than the expected distance of 2 millimeters. And they got a range that varied between less than 1 millimeter apart to more than 3. And so why was that happening? What was happening is when they put those electrodes in, they would buckle. They'd bend a little bit to the right or left in a random fashion, and that would randomize their locations, causing inaccuracy or imprecision in the lead placement. And just to sort of drive this point home, this is a little cartoon I created here on the right, which shows the subthalamic nucleus in actual size, not actual size, but blown up. It's a scale, I should say. And this is a grid that you're trying to use to search to find the exact right location within the subthalamic nucleus. And this is the grid you're trying to use. But the below is showing the grid that you actually got based on the statistics from this paper. And you notice how it gets really randomly reassorted, and sometimes you end up way off where you intended to be. And this is why we're getting inconsistent results. This is a picture from a paper which really illustrated this point well, where they put these electrodes in place and they looked at all the different contacts on the electrode and they looked at it inside the subthalamic nucleus and they said, gee, how many times doing this the traditional way do we actually end up getting inside the subthalamic nucleus? And this is their results. And it turns out they were aiming for the area highlighted in the pink. And if you notice, they got into that highlighted area, the pink, less than half the time. That's not very good. It turns out they actually got into the part in the green, and you can actually, this matches up with this diagram back here. You have that purple part's the pink part, the green part's the green, and then the other colors match up. Turns out if you're in the green part, it works just about as well. And how well they work is shown on this scale on the right. The lower scores are better. So untreated person is black, those scores are higher, they're worse. The blue scores are where a significant number of leads ended up, but notice they did not do as well as leads that were placed in the green or pink sections of the STN. In other words, they missed in a significant fraction of the time, maybe around 40% of the time, and that miss led to a suboptimal clinical result. In other words, those patients didn't do as well. And the worst yet is they did better than they did at baseline, so you ended up not knowing they could have done better. So we thought we have this foolproof method, but it's not foolproof, and we're getting results that aren't as good as we thought they should be. So how do we fix this? Well, we fix it with robotics. So this is a picture of a robot. You kind of have that picture of Will Robinson in your head when you think of a robot. In this case, it's actually just a little thing about the size of a Coke can, and it mounts to your head. So a little arm comes off the side, and that arm pivots to just the right location to line up the electrode. We can actually see the target in the brain on an MRI. This is the target on the subthalamic nucleus. This is an old MRI. Our newer MRIs have been fine-tuned to the point that we can see it very, very well. And so we're using Parkinson's as a model here. We can see all the targets really quite well where we want to put the electrode. And then if we can see the target, and we have a robot, we should be able to line it up and put it accurately in place. And indeed, that's what we do. So this is the robot mounted to somebody's head. This one's blue, some of them are green, some are blue. Little arm comes off the side. I don't shave people's hair. This gentleman just happens to be bald. So if you come to me for your surgery, you'll look just like you looked after the surgery as you looked before. And you can see this little arm comes off, and there's a direction for the cannula to go in place. Now the robot doesn't do the surgery, it just acts as my guide. I do the surgery. This donut around this is not an MRI machine, but a CAT scan machine, and it's used to confirm the location of that cannula. So it's used to match up with that MRI one-to-one, so that I can see exactly where that electrode is. And this is actually a picture of it. This white dot measuring 1.8 millimeters across, you can see is inside the subthalamic nucleus. It's its actual position, and that white dot is where the lead is going to go. That's a cannula that will contain it. This is actually a conglomerate picture of the MRI done before the surgery and the CT scan done during the surgery, showing me the cannula on, which is the introducer to put the lead in place, showing me the cannula on the CAT scan and showing me the brain on the MRI and showing me that I have the electrode in the right location. So now we can't have that situation we had before where the electrode skives off one direction or another direction and we didn't know it. Now we know it. Now we can see where it is. A big side effect of this technique is because I'm seeing where it's going, I don't need to test anything, therefore I don't need the patient to be awake. Because the patient doesn't have to be awake, the operation now is a lot more comfortable and also a lot faster. And because it's a lot faster, the infection rate and the complication rate drops. And so we actually have a lot less chance of having a complication or a problem from the surgery. And so we actually did this, and we did a little study from it. It's published in the Annals of Biomedical Engineering if anybody's interested in seeing it. I'm the senior author on that paper. And what we did is we looked at the actual lead placement, the intended trajectory, and we showed that we deviate less than a millimeter on average for placing the electrodes in position. So let's take a little look at another new innovation, and that is directional stimulation. This is as transformative as robotic surgery is. So robotic surgery and doing it asleep really has transformed the surgery, making it much safer, much faster, much more comfortable, making it really more the standard of care and less something that looks kind of like an erector set. Directional stimulation is just as important, and I want to show you what that is. So what that is if you look at an electrode, here's an electrode, and this shows you 4 contacts on it, 1, 2, 3, 4. And typically, the contacts used to be where they would wrap all the way around the electrode, and you'd have 4 contacts total. Now we have 8. So if you see, they have contact 1, then contact 2 is split into 3 components, and then contact 3 is split into 3 components, and then contact 4 is a single component. So there's 1, 3, 3, 1. And what that allows us to do is these 2 inner contacts, which we use more commonly than the other contacts, we can turn on, say, 3A or just 3C or 3A and 3C together or other combinations. We can actually steer the electrode or the electrical current forwards or backwards or left or right or up or down. And that is just like we moved the electrode, even though we didn't actually move it. So I'm placing the electrode with a high degree of precision using a robot, but we can fine tune it even more with directional stimulation after the fact. Again, getting a more precise placement, again, precision being the theme of the day, and more precise stimulation, therefore better overall results. And that actually plays out. This is some of Abbott's studies. And if you notice, if we turn up the current, eventually we'll get a side effect up here at the top. And if we don't turn up the current very much, we don't get any effect at all. We don't get any benefit. And between those 2 levels is the therapeutic window. So turned up enough that we get a benefit and not so much as we get a side effect. And it turns out with directional stimulation, there is a 35% increase in that window. And so just go back is that window, that therapeutic blue part there in the middle, that number 2 section, that's 35% wider than it would be if we didn't have directional stimulation, making it less likely to get a side effect and more likely to get a positive effect. Another benefit of it is we stimulate lower. So we use less overall stimulation because the stimulation is right where we want it to be. That means 30% reduction in stimulation translates literally into longer battery life, literally almost 30% longer battery life, not quite, but almost. And it turns out that most people benefit from it. When this first came out, many people thought, well, it doesn't really matter that much. Only a few people can benefit. It turns out about 85% of patients will benefit from using just a single segment with that wider therapeutic window. So most people can be programmed really well using what's called ring mode, using all the contacts all the way around, if you place it really well. And so we tend to place it well so our patients can be programmed well. But if we go to a single contact, or a contact in the right direction, we can make it even better. And it turns out that's true about 85% of the time. Clinicians, when they program, the vast majority, about 4 times as many clinicians, sorry, I said it incorrectly. In 4 times as many patients, clinicians will say the patient programmed better if they had directional stimulation, and about twice as many patients will feel better with directional stimulation. So both the programmer as well as the programmee, if it were, felt they did better with directional stimulation. So I think if you take away a couple of things from this, robotic surgery gets the lead very, very well placed, and directional stimulation allows us to fine tune it even better. And if the stimulation is exactly where it needs to be, you'll get better. Those are key pieces. So what are the measurables? What did we achieve with this? Well, one of the things is surgical time. This is actually from a publication done by Viva Abosch, who used to be here in town and now is in Nebraska. And this is a whole bunch of different surgical techniques that exist out there. And in that same study that I published in Annals of Biomedical Engineering, our average surgical time, this is from the time you enter the room to the time you leave the room, so it's actually a little bit longer than the actual surgical time it takes me, about 140 minutes. Whereas if you look at all the different ways a surgery could be done, there's just all these different programs all these surveys of all these different places they did. We are as fast as the fastest program out there. Everything else is slower. And that's incredibly important because that reduces your complication rate. So in our survey group, we had 241 leads placed. One of them got an infection in that group. And since then, we've had 2 more infections, but we've done about 3 times as many more leads since then. So our infection rate is well under 1% since we've switched to this methodology. But the average infection rate, if you look at a comparison, this is a nice study published by Oslo University, which I think does a good job. They just do it the traditional way. They have about a 3.5% infection rate. If you get an infection, the whole thing has to come out. You have to treat with antibiotics for a number of months, and you have to put it back in. So the new thing we should be talking about really in deep brain stimulation nowadays, after we've gotten past the precision issues, what's the complication rate? So what's the rate of problems? And our total complication rate for all kinds of problems is right about 1%. That includes everything from bleeding in the brain to infections to batteries that can sometimes flip around on themselves and have to be fixed. So all the problems, so we have about a 99% chance if we do this in this sleep robotic technique that you won't have a problem, that everything should go well. And that's actually the new thing I think we should be talking about in deep brain stimulation. No longer does it work? No, it clearly works. The question is, what's the chance that it's going to go perfectly well in your case? So I'm going to end the presentation here with one of my patients. I just changed his battery actually just on Monday. One of my favorite individuals. He's now 53. This is him at 51 rock climbing. He's an ex-U2 pilot, ex-jumper on the Air Force jump team. He used to jump into the Rose Bowl and used to fly for United. Has severe Parkinson's and it doesn't let him stop. He has DBS and he's doing all these things with a DBS system in place, allowing him to live his life to the fullest. He's allowed me to sort of share his story, so I appreciate that very much. The reason I met him, by the way, is my partner, Dr. Prawl, so also at Neurosurgery 1 with me, does mostly spine surgery, et cetera. He trusted me enough. This is his best friend from high school. So he's the one who allowed me to work on him. Now I'm going to take a little pause for a second here, and I'm going to try to switch and show some videos, which I think are really poignant. So I may, in doing that, have to mess up what I share, but let's see how this works out. I'm going to play a video here, and I want to share that video. Which is always a little interesting. Okay, and QuickTime Player. And I think victory has happened here. So I'm going to talk about this. I'm going to turn down the volume here.
See little dyskinesias in the hand there. Don't hide your hand from us.
Okay. This is my first patient that I ever operated on. And he has severe dyskinesia. And he alternates between terrible dyskinesia and rigidity. The reason he had his operation was at the time was that he had young kids and he would take them to their sporting events, etc. And his either dyskinesia would act up, or because his medications were too strong for him, or he would get rigid and freeze and he couldn't drive. He had to call his wife, and his wife come get him, and then they have to go back after his medications were adjusted, get the car, and he just wasn't able to participate in life that well. And so he decided to have DBS. And this is in the early days of DBS. We were doing it all awake back then. This is him with rigidity and bradykinesia. So now he's in an off period. His medications have worn off. And so he's very slow. Doesn't have the dyskinesia anymore, but you see that his left hand has tremor. The right hand is very slow. I'm asking him to tap his fingers. He doesn't freeze, but he does shuffle. You'll see that as he walks. And so he just wasn't able to participate in his life. And so he was willing to sort of, at that time, do something rather avant-garde and get a DBS. This is 15 years ago. This is a long time ago. So watch how slow he walks. Watch his facial expression is really stiff. You can see how rigid he is on the left side and tremor. Now we've got him off his medications before his surgery. So now he's really slow because his medications are off. Notice he and his wife are standing there together, and they're the same age. So, but he looks much older because of the Parkinson's disease, or they're similar age. We're asking him to turn his hand as fast as he can, and that's the best he can do because of the Parkinson's. He's trying to open and close his hand as fast as he can there, but that's the best he can do. He's asking him to tap his foot as fast as he can, but that's the best he can do.
Fast as you can. Okay. Another foot. Fast as you can. Good.
Now the surgery's been done, and we're going to go through our first programming. The stimulator's now off. We used to program in the hospital. We don't anymore. You program at home or in a clinic, but this is in the clinic. This is Dr. Alexander, who I still work with today. She's a neurologist, and she's noticing symptoms, noting rigidity, noting facial expression. So the surgery's been done, but the stimulator is not turned on. What she feels there is the rigidity in the arms. It's something you can feel, and he feels. So he's asking to tap. Notice how the tapping gets smaller and smaller and smaller when he taps. And on the left side, he's trying to tap, but he really struggles. He barely can do it. Now he's going to try to flip his hand over the best he can, as fast as he can. He doesn't freeze, but he does shuffle, and there's no arm swing. You see the tremor. If you get him talking or distracted, the tremor is worse because it's a resting tremor. That's typical of Parkinson's disease. Now we turn the stimulator on. First day, first programming session. Same guy. Remember before? Remember lack of arm swing, the lack of the slow movement? How he couldn't turn very quickly? Now he's starting to look kind of normal. This is just still the first day of programming. Now she's going to ask him to do things here. She's noticing how loose he is, how loose his muscles are. Noticing how loose the muscles are in the legs now. Now remember how slow he was before? That's normal. You couldn't tell that apart from somebody who didn't have Parkinson's at all. Remember that left side that he couldn't move at all hardly? That's normal now. So asking to do it big and tall. So he couldn't do that kind of amplitude at all before. Remember the rapid finger tapping where the fingers got smaller and smaller and he barely could do it? Same thing there. And remember the left side he couldn't do it at all? Same thing for the feet. So look at the speed of his movement now. It's day 3. Other than maybe a little bit of facial expression, you really can't, his arms are swinging almost equally. If I saw this guy on the street, I wouldn't be able to tell he had Parkinson's. Now, you can't wipe out every symptom of Parkinson's. You can't certainly cure it. It's always there, but you can back up time. You can make it look like he looked 5 or 7 years ago. In any case, I felt that was fairly dramatic to share. I want to share one more video. Again, look at the speed. It's just fabulous. My first patient ever. So he's the reason I spent so much time trying to perfect this surgery. His surgery worked so well, and it was an awake surgery. I did both sides. It took me 7 hours to do that surgery. I'm going to show you one more video. Nowadays, we do that whole surgery in an hour and a half, asleep robotically with radically lower complication rate. So I'm going to share this when I get it to kind of the right spot here, about 5 minutes in. Yeah. This was going to be a little bit blurry, so I'm going to apologize for it. Let me get this put up. It was shot in a very small format with a phone. This is also one of my early patients. Very dear to me. And the video is fairly short, it's just a few minutes here. And we'll see her with her system turned off. She's on right now, so she looks pretty normal. Now she has essential tremor. And you watch her move around in her hands and her head, you don't really see any tremor at all, and she looks pretty normal. That's also Dr. Alexander. Now Dr. Alexander is going to turn this off. And her symptoms will start coming back. And now she has an intention tremor, so if she tries to hold her hands in a position, she'll have a tremor. This is one of the worst tremors of any person I've ever met in my entire life. But we were able to almost entirely stop it. It almost looks like she's faking it, but she's not. She lives like this and lived like this all the time. And with the system on, we could entirely stop it. And then Dr. Alexander is going to turn it right back on because we don't want to have her suffer and leave it off all the time. So you saw her before and then immediately turn it off and the tremor immediately comes back. So that's probably all there is really instructive from that video. So I'm going to go here. So thank you everybody for joining me. And I think at this point, thank you for spending an hour with me, and I'd be happy to take any questions that you might have.
All right, thank you so much. That was wonderful. Currently, we have no questions. Just a reminder, you can type them into the question bar or raise your hand and I can unmute you.
Got a quiet audience.
Yeah, nothing coming in. It'll be a few more minutes, a few more seconds. It was a very informative webinar. You answered everything.
No, thanks. It's like the ... waiting for somebody to type on your cell phone. You have the anxiety. What are they going to say? I don't know what they're going to say.
All right, well, with that, a question came up. How long does the benefit last, or does the neuron burn out?
It's a good question, and I didn't cover it, so thank you for bringing it up. The effect lasts forever, so the neurons don't burn out. But if you have Parkinson's disease, or even if you have essential tremor, the disease will get worse with time. That's just inherent in the disease process. Generally speaking, with essential tremor, even if the disease worsens, we're able to control that tremor generally for the rest of your life. On the other hand, with Parkinson's, we're really able to back up time. That's probably the best way to look at this. If I can't cure the disease, and the disease will get worse, and the disease will get worse in a way that the DBS can only partially treat it. But at every moment in time, you'll always be better off than you would have been had you not had the DBS. So if you're 5 years into your disease and you get DBS, oftentimes you will look like you don't have Parkinson's at all. But if you're 15 years into the disease process, I can't make you look like you don't have the disease at all. You know, you'll still look like you have Parkinson's disease. But on the other hand, you'll look more like you were 10 or 5 or 10 years ago. So you're 5 years into the disease or 7 years into the disease, something of that nature. So the easiest way to look at it is it works forever, but it backs up time.
Great. Okay, we have 2 more questions. How long after the surgery does the programming start? Immediately?
No, there is a bit of a delay. And it's different for different neurologists. We work with a lot of neurologists. It's important to say we also have an open program. We work with any neurologist you have. So most programs are closed. So if you go to a particular location, they might work with only people in their network or at their academic center. We work with anybody. And different neurologists have different ideas about this, but all of them usually want to wait 1 to 3 weeks after the surgery before they start programming. That's very typical. The expectation should be very different with essential tremor and with Parkinson's. With essential tremor, oftentimes 3 or 4 sessions is all it's required, and you can get most of your tremor under control with some minor adjustments, you know, every 3 to 6 months over time. And some people require so little adjustments that they actually don't even bother checking their battery for a few years. So please don't do that, because I don't like those phone calls when the battery dies. With Parkinson's, on your hand, it's more difficult to get the system adjusted, and it can take anywhere from 2 or 3 visits to as many as 6 or 8. And because you're adjusting multiple things, you're reducing your medication utilization. You have sometimes what's called a micro lesion effect in the brain, where you get a little benefit from just putting the electrode in by itself, even without turning it on. That's wearing off, and then you're getting an increasing stimulation benefit. So you have these moving targets that makes it much more difficult. You should expect from the time you do surgery with someone like myself until the time you're really as good as you're probably going to get with Parkinson's is going to be about 3 months. So through all the steps of surgery and then through all the programming sessions, it should take about 3 months.
Great. And then does DBS slow down cognitive decline?
No, it does not. It's controversial whether it actually increases it or not, and I don't believe that it does, at least not in most cases. There are some people that would differ from that belief, and so we do get neurocognitive testing for every single person before we do surgery. But on the other hand, there is no evidence at all that it would slow down cognitive decline. I wish that it were.
All right. How bad does balance have to be that you wouldn't get the surgery?
Actually, I don't think it's a limiting factor. You couldn't get the surgery at all. Cognitive issues are a limiting factor. Balance is not a limiting factor. It's just that it won't get better. So that's an incredibly important thing to know. It's not going to get better because of DBS. Now, something I think it's really important to bring up is many times I have diagnosed individuals with other diseases when they come in with Parkinson's and balance problems together. So I've commonly seen an individual who comes in and goes, hey, my doctor said I'm probably not ready for DBS, or it's not going to be good for me because I've got this bad balance problem. And then I MRI their neck and their brain, and I find very commonly in the neck something called cervical stenosis, where it's pinching the spinal cord because of a disc in the neck. And that's the source of their balance problems, not the Parkinson's disease. The Parkinson's disease will cause balance problems, but usually very late in the disease, down the road. And oftentimes those other issues get ignored because we just routinely blame it on the Parkinson's. Oh, you have Parkinson's, so this problem must be from Parkinson's. And oftentimes it is not. So if you have balance problems, there are a lot of causes for balance problems, a lot of inner ear causes of balance problems. There's pinching of the spinal cord. There's vision problems. There's peripheral neuropathy, another very common cause for balance problems. All of those should be explored before you say, hey, it's just the Parkinson's.
Great. We have 2 more questions that we can maybe squeeze in. Does DBS interfere or complicate with other types of surgery, like orthopedic surgeries?
Generally, no. The newest devices have surgery modes. You can actually turn it into the surgery mode yourself. Reps will come if necessary. The other surgeons are getting quite familiar with these things being available. You should be able to get most any other surgery you would need. You can get MRIs nowadays with all the major vendors. They have it's much more well worked out now. You can get a high quality MRI of most any part of your body. So if you need an orthopedic surgery or other type of surgery, you should be able to do it without difficulty.
And the last question, after surgery and before programming, do you take your medicine?
Yes, actually. So for the awake surgeries, no. Back in the old days, you would quit taking your medications to make your symptoms really, really bad, and then you would test those symptoms during the surgery. But now with the sleep surgeries, we do it entirely based on imaging, so there's no reason to suffer. So we have people take their medications right up until surgery and then start taking them right after they wake up. That's not true for blood thinners. If you're taking blood thinners like aspirin or Eliquis or Coumadin or things like that, we have to have you off those for a period of time. Some blood pressure medications we have to pay attention to as well. But your Parkinson's meds, we have you take them right up to surgery and right afterwards. There's no point in suffering at all.
Great. And actually, one more question. How long does it take to get through the evaluation period?
It's much faster with us because we do everything in parallel. So what I mean by that is you can't take shortcuts. There are workup things that have to be done. I got to make sure that you're healthy enough to have surgery. I got to make sure that if it's a Parkinson's patient, that the cognition is there, and so we have to do neurocognitive testing. I got to make sure that you have a neurologist that can do the programming and definitely is on board with doing this. And so all of those things have to be done. You can't take shortcuts, but they can all be done at the same time. So instead of doing one evaluation, coming back and meeting as a committee, doing another evaluation, coming back and meeting as a committee, and dragging this out for sometimes a better part of a year, we generally, from the time you see me until the time you can actually do surgery, is under 3 months. So usually 2.
All right, great. And then there's one more question, if you'll take it.
Yes, of course.
Okay. What immediate care is needed after the surgery? I live alone, so will I need help at home until I get the first programming? How soon can I start up my exercise again?
That's an excellent question. And I'm going to give you 2 different parts to it to answer it fully. So remember I said that placing DBS electrodes does not cause cognitive decline, or likely does not cause cognitive decline. It can cause it temporarily for about a week or so. And so having somebody at home with you for that first couple of weeks, I think, is very helpful. So I would recommend that for all my patients. You can do everything on your own to take care of yourself, but having somebody there to take care of all the household needs, making sure there's food, making sure that you can run around to your appointments, etc., that's really, really helpful. The other thing I think it's important from the exercise perspective is a completely different answer. The generators are kind of heavy. So not really heavy, but have a little bit of mass to them. And so if you do vigorous exercise, they can actually displace and move around a little bit. And so we want to hold you off on some of those things with exercise where they might jiggle around or get loosened for a couple of months after the surgery. Now, on the other hand, exercise where that doesn't happen, you can do right away.
Great. Well, those are all of the questions. Again, I'd like to thank Abbott for sponsoring this webinar. Without sponsors like them, we wouldn't be able to have such informative and wonderful information. With that, Cindy, if you'd like to say anything else.
Thanks again for joining. I appreciate it. Thanks, Dr. Van Sickle.
I thank you all for coming, and we're happy to answer any questions that you guys might have. And I think that if anyone wants to contact me, you can contact me through PAR, or what you do is look for Denver DBS Center or our parent company, which is Neurosurgery One. We're happy to see you anywhere. Just look up my name. Easy enough.
All right. Thank you so much. Enjoy the rest of your night.
Bye all.